interpreting of ECGs, particularly tomorrow, and interpret some common findings. And I'm going to sprinkle in a bit of investigation and management, but obviously let me know if it wildly varies from what you guys learn. So hopefully this is vaguely familiar. So in the heart, our electrical activity, which is what we're going to measure with our ECG, comes first from the sinoatrial node across our atria to our atrioventricular node, down our bundles, and then across our ventricles and upwards. This it has a deep place in my brain that I don't really remember, but effectively, if this looks more familiar to you than me, we're measuring the depolarization and repolarization of the heart, so it becoming more positive and then more negative, and that will help us map out our ECG. So again, the ECG is literally recording that change in charge, so that's where we get all of the waves from. And the waves will, the amplitude, so the height of the waves will depend on how directly they're looking at where the electricity is coming from. And again, that's going to be really helpful, particularly in us working out where things like STEMIs are coming from or where the issue is in our ECG. I'm going to very briefly recap the electrical cycle of the heart, just going to kind of race through this, but again, let me know if there's any questions and then we'll get on to the actual ECGs. So again, it starts at the SA node. That doesn't create a wave on the ECG because it's too tiny, but then that spreads over our atrium and that creates our lovely P wave, and we'll talk about why that might look different in a little bit. Then we have a delay at our AV node, so that's on our ECG what our PR interval is going to be. That lasts from 120 to 200 milliseconds. And again, we'll talk about the reasons and what we might see on an ECG if that is different. And then it's going to go over the bundle of His. So that's the only place that the atria and ventricle should have a connection electrically. And then down our bundle branches and our Purkinje system. That's going to then spread over the septum, as we said, and that's going to create a very little Q wave that tends to go from left to right. And pathological Q waves is definitely something I did not understand at medical school. So hopefully I'll explain what they are and why we care about them. And then we're going to have our depolarization of the ventricles themselves. So that's going to be our big QRS. So obviously the bigger the amount of muscle, the taller that's going to be. So we could see signs of hypertrophy, for example, or hypertension. And depending on where that R wave is biggest, for example, might show us where there's more muscle mass or where there's less muscle mass, and that'll also give us some idea of pathology. Then at the end of depolarization, so we've kind of gone down, up and across, and then we're going to get our tiny S wave as we're coming upwards. And then that entire QRS should be less than 120 milliseconds as your time to remember for that one. And again, we'll talk about what the causes of that being longer and the significance of that will be. And then we've got repolarization, so that's going to be our T wave. So that is us becoming the opposite amount of charge in the kind of opposite direction. So we get our upwards wave with that. So that was a bit of a blast of electrical cycle. So we'll briefly mention the performing of the ECG because it's helpful to remember where the leads go, because then that helps us interpret things. And then tomorrow we can cover that in a bit more detail if wanted at the end. I've basically made one mega presentation so that I can send it all out to you in one go tomorrow. So our leads, we've got 6 chest leads and 4 limb leads. They're the kind of stickers that we're going to put on, and that will give us our variety of views. Our limb leads, does anyone know, if you can shout out what the limb lead colours are and kind of where we tend to put them when doing an ECG?
I don't think anyone's really sure, to be honest.
That is absolutely fine. No, so this is something that will probably be stuck in your head from now on. But so we tend to have ride or red is the right arm, and we kind of start there and then work round. So it's ride, yaw, so left arm is yellow, green is the left leg, and then black right leg. So it'll look a bit like this. It's still, when I put on ECG stickers, I'm going ride your green bike because that's the only way I can remember. I think the chest leads are a bit easier because they are literally labelled from 1 to 6, and they also tend to come with a nice little diagram to help you. For the chest leads, important kind of landmarks to know, and sometimes people get this a bit confused with listening to heart murmurs, I think. So sometimes people start in the second intercostal space, but it's actually all the way down in the fourth. If you watch many medical dramas, they're always in the complete wrong place. But so on the right sternal edge, it's the fourth intercostal space, and then you mirror that across on the left for V2. Then V4 is fifth intercostal space mid-clavicular line, and then 3 just stick a sticker between 2 and 4. And then the next kind of landmark is 6, which is your left mid-axillary line, and you kind of just follow V4 round, and then again you put 1 between. So it should look a bit like these diagrams. With these, you'll effectively get 12 views of the heart, so that's because of the combination of these leads gives us different views of the heart. Chest leads, it's quite easy to work out what they're looking at, because it's basically looking in where you've put the stickers. So V1 is looking at the frontal kind of septal part of the heart, because the heart is tilted, all the way round to V6, which looks at the lateral side of the heart, as you can see in that diagram. And again, so obviously our heart doesn't sit straight on, it sits slightly curved. This is really helpful when we think about STEMIs and kind of where different views of the heart are. So it's just helpful to know the anterior is kind of V3, V4, septal V1, V2, and then lateral V5, V6. The limb leads, so that's our ride your green bike, that gives us 6 different views of the heart. You'll see me doing lots of dancing when I'm talking about this, because I still, again, when I do ECGs, have to think about this. But effectively, the views of the heart are AVL and AVR. So that's your left shoulder and your right shoulder is how I think about it. So they look at the top part of the heart, right and left, or left and right. Lead 1 comes in kind of at the side. So that looks at the lateral part of your heart at kind of 90 degrees. AVF, I think of it as like your feet, so that comes straight up from the bottom and looks at the inferior part of your heart. And then lead 2 and lead 3 come in at kind of that sort of angle underneath. That's going to really help us again when we think about if there is signs of left or axis deviation because of hypertrophy. We'll be able to tell where there is extra muscle depending on effectively where that dial has swung to. So normally our left ventricle has obviously got the most muscle. So the axis of the heart points kind of towards the left foot area where lead 2 is. But obviously if you've got more muscle on the left, it'll kind of point more to the left. If you've got more muscle on the right, it'll point more to the right, but we'll cover that when we do the axis. You may have seen cardiac monitors on the ward. So obviously when people are hooked up to a continuous monitor, we don't have all 12 leads on them, because inevitably the reading would be really rubbish because they get tangled and lots of things interfere. So we just tend to do 3 leads. Similarly, it's ride your green this time, so it's red, yellow, green, so just the 3 leads. This tends to give you one kind of simple tracing of the heart. Sometimes you get kind of more than one, but normally just one line. And it means you can kind of continuously monitor if you're worried about any arrhythmias coming up, depending what someone's got going on. That's always quite a good answer if you've got someone with a rhythm in an exam question you're worried about, is hooking them up to a cardiac monitor. It's a good idea. So now we'll do the kind of big main bit, so interpreting the 12 lead ECG. I'll sort of map out what the structure we're going to learn is, and then I said we'll do lots and lots and lots of practice tomorrow, but within each bit that we're going to cover, I've tried to kind of go in detail of all the things you could ever need to know of that section. So again, hopefully as we're going through systematically, you're not going to miss anything on an ECG. So easy one to forget, but definitely always just check you've got the correct name and date of birth, and particularly when you're presenting back, it's something that's really easy to forget. So this is the ECG of X person with their date of birth. It can be helpful to know the date and the time. So is this actually the current ECG that you wanted? Sometimes they'll be numbered, say if someone's had chest pain and they're having multiple ECGs to check for any changes. So kind of check you are looking at the one that you want to look at. It can be helpful to know the reason. So often if you're in A&E, someone might hand you an ECG and it says the word chest pain on it. Immediately, you probably forget all of this nice order we're going to do and look straight at the kind of ST segment, or, you know, for any signs of ischemia. So it can also hinder you sometimes. So say if they say, actually, this person feels fine, you might only glance at the ECG, was really just make sure that you're thoroughly looking at every ECG that you look at. I don't know if any of you have heard of the gorilla experiment they did with radiologists, where they asked them to look for lung cancers. And actually, I can't remember the percentage, but an incredibly high percent of them missed that there was a gorilla on the ECG. So always just be worried, be mindful of diagnostic bias, but it can be helpful to know why the ECG is being done. So you've looked at the name and the kind of date of birth, you've checked the details, you're happy this is the right kind of time and date. So that's step one. We're going to check that the ECG is correctly calibrated, so the right speed, and they're the key numbers. And again, we'll talk about that in a second. We're going to check the rate and the rhythm, and then the axis of the ECG. And then we're going to go through kind of wave by wave. So we're going to look at the P wave. Are they there? Is every P wave followed by QRS? The PR interval. Are there any pathological Q waves? Does the QRS look normal? Is it narrow or broad? Is there good R wave progression? Is there any problems with the ST segment, so elevation or depression? What's the QT interval? And do the T wave look normal? Are they inverted? Are they kind of bigger than normal? So there's quite a lot to cover, but the more we practice, the slicker you'll get at doing each thing. So we'll go through each bit step by step. So we've done the name and everything. For the calibration, so your key numbers are 25 millimeters per second and 10 millimeters per millivolt. Standardly, that's what most ECGs are already set to, although I had a bradycardia in A&E the other day where the calibration was wrong. So if you actually calculated the rate, which we'll explain how to do in a second, then the rate came out at 20. So obviously I was quite alarmed when I read the ECG, but it was miscalibrated. So actually it wasn't as catastrophic as it at first looked. And I had to do another ECG with it recalibrating the machine. It helps us to calculate the times. So because it's 25 millimeters per second, we know that each large square is 5 millimeters. So there's 5 large squares per second. So you can work out that there's 300 per minute. Hopefully that makes sense. I have to spell out all the maths, otherwise it blows my mind. And then we also know that there are 5 small squares and a big square. So each small square is 40 milliseconds, and therefore that we can work out there's 1,500 per minute. These numbers will become lodged in your head, but for now, they're on there. So this is kind of that in a diagram form, which I think can be quite helpful. So we've checked our calibration, and then because we know it's calibrated right, we can calculate a rate. Obviously, rate effectively is how many beats there have been per minute. So if we take someone's pulse, we know it's 80 beats per minute. We want to look at how many beats there are on the ECG per minute. Each R to R interval, so the QRS is the ventricles contracting, so that is a beat. So if we calculate basically how many R to Rs there are, we know how many beats there's been. Because we know there's 300 big squares per minute, if we divide 300 by the number of large squares between the R to R, that will give us a rate. And I'll show you an example. Oh, well, you can do it with the small squares. Obviously, they're harder to calculate because they're really tiny. But if you've got a really, really, really quick rate, that's the safer way to do it, because otherwise you're sort of going always at a 2.1 big squares, 2.4 big squares. But actually, if you count the individual small squares and then do 1,500 divided by that, that's how we can do a rate. Obviously, the faster the rate, the less squares there will be between. So you can see if actually we had a rate of 150, there's only 2 big squares between. Whereas if it's a rate of 75, which is more normal, we've got more big squares between. So can anyone calculate the rate of this ECG for me?
$25.
Yeah, I think I can't remember the exact figures in my head, but so effectively it's 300 divided by about 4.5 as I've calculated there, which is about 665. Do we all kind of understand how we got to that bit? Shout out if you don't. The other way to calculate it, and probably the one that people use because it can be a bit easier than doing 300 divided by things in your head, is we particularly use it in irregular rhythms, but is to use the rhythm strip at the bottom. So that's where it's lead 2. You get a 10-second strip at the bottom of your ECG. Because it's 10 seconds, if you just count how many beats there are, so how many QRSs, and you times it by 6, then that gives you the kind of average number, and that's your rate. So similarly, can anyone calculate the rate on this one for me? The rhythm strips there at the bottom as lead 2. It's not a super easy number to times by 6, to be fair.
About 100, 102.
Yeah, oh yeah, about 100. It's not a bad shout. So yeah, 102 for that one. And you can see that for that one, because it's irregular, so the beats aren't kind of aligned, regularly. That if you calculated the number of big squares between, you'll get wildly different rates depending on which bit of the ECG that you pick. So that's why we tend to use the ×6 method. So for our heartbeats, and we'll talk about tachycardias in the next session, and we'll do a bit of bradycardias a little bit later on in this one. But our normal heart rate we're hoping to get is kind of 60 to 100, tachycardias over 100, and bradycardias under 60. We worry about bradycardias when someone has an inappropriately slow heart rate. So obviously with athletes, their heart could well be going at kind of 40 or 50, but they're fine. But actually if their blood pressure is low, they have rubbish urine output and effectively poor cardiac output, signs of heart failure, or if they're getting escape rhythms because the heart's going slow, so the ventricles try and take over and you're getting kind of odd arrhythmias, they're times that we worry about bradycardias. We'll talk about it in more detail with the PR intervals, but it's basically normally a pacemaker problem. Some of the signs and symptoms you might get were people collapsing is kind of often the big one. Sometimes palpitations, and it's always good to get someone to tap out their palpitations, because actually if they're just feeling their heart going really heavily but very slowly, then that's kind of, obviously normally palpitations, we think about people's hearts racing. Sometimes confusion depending on kind of blood supply to the brain, shortness of breath and kind of signs of heart failure, and it can cause sudden cardiac death. So normally it's a fault of the pacemaker because effectively the heart is pacing too slowly. It's normally a problem with the atrioventricular node, which we'll cover in more detail. I'll quickly talk about the sinus node. So you obviously, as I said, can have a sinus bradycardia. So actually that's normal for you. Your heart just goes more slowly because it doesn't need to go as fast, often in athletes. And there's no actual kind of pathology causing that. Sometimes if your sinoatrial node is damaged, that could be ischemia or fibrosis or a cardiomyopathy. You can get sick sinus syndrome. I'll show you an ECG, but effectively your heart goes really fast, really slow, really fast, really slow because the pacemaker isn't working. Medications, so particularly things like beta blockers, can affect the sinoatrial node rate and make it too slow, and hypothyroidism as well. Because it's a problem with the actual sinoatrial node going very slowly, your PR interval, so that's that delay that's normally there at the atrioventricular node, isn't affected. So you can see on here our PR interval is nice and normal, but we'll talk about the AV node bradycardias because normally that's a problem and you get a widened or kind of changed PR interval. And if these people are symptomatic, they will need a pacemaker. So this is sick sinus syndrome. So you can see it goes very fast, very slow, some worrying bits where it doesn't seem to be doing anything at all. And as you can see, that's putting you at quite high risk of asystole or kind of arrhythmias that are going to cause you some problems. That can be caused just by aging, but also ischemia, myocarditis, fibrosis, anything like that. And so we'll talk about the AV node. So there are heart blocks that tend to be a bit more common and definitely always come up in exams, but I'll talk about them when we get to the PR interval. Tachycardias, as I'm going to cover that tomorrow, so that's more of the kind of specific ventricular tachycardias, etc. So far we've done our name, time, date. We'll check the calibration as 25 millimeters per second and 10 millimeters per millivolt. We've done our rate, and next we'll do our rhythm. So for our rhythm, it's best to look at that 10-second strip because then you can tell if it's a bit more difficult between our leads because it's kind of moving from lead to lead at the top. You can also order an extra long rhythm strip on your ECG that can last up to kind of often a minute. So again, you can kind of look out for those signs that things are going irregular. I still do the method, and as do many cardiologists who work at my hospital, where you get a piece of paper. Effectively, I tend to do 3 marks matching up to the top of the R waves. I tend to do, move it along and see if it all lines up. If it all lines up, it'll be regular. If it doesn't all line up, it's irregular. And you want to know if it's regularly irregular. So is it dropping a beat every 4 beats, for example, or is it all over the place, irregular, no pattern? So that would be similar to this one, where it hasn't really got a particular pattern. So we've done name, name and date, calibration, rate, rhythm, and now we're on to axis. So this is where it comes into importance in terms of what of the chest lead, of the limb leads looks at what. So the heart, because we've got the biggest muscle bulk on the left ventricle, tends to point kind of towards the left foot, which is lead 2. If you've got extra muscle bulk on the left, you've got a left ventricular hypertrophy, you'll get a left axis deviation, and actually your most positive lead, so we're looking for the biggest spike here, would probably be in lead 1, which is the one that comes in at like 90 degrees on your left. If you've got right axis deviations, you've got a right ventricular hypertrophy, that's going to point more to the right side, and it's going to look more at your kind of right foot angle, which is kind of lead 3. I tend to look at 1, 2, and 3 because they sit next to each other. I'll show you some examples. You can always then double check. So for example, if you think there's a left axis deviation, lead 1 is super positive, but then also AVL, which is the one that's kind of your left shoulder, will also be more positive. If it'll make sense. So again, you're just looking at basically where that dial is swinging as you're looking for the most positive lead. So in this one, which is the most positive, effectively like the tallest R wave between 1, 2, and 3?
2.
Yeah, this is our normal kind of axis. This is what we'd expect for most people. So that would be a normal axis. Whereas in this one, from 1, 2, and 3, which is the most positive?
3.
Yeah, so this, and I said 3 kind of points towards your right foot. So this is a right axis deviation. You can kind of check by saying, so AVF and AVR are kind of more positive than normal as well. And lead 1 is quite negative, so we're definitely pointing towards the right side. So that would be right axial deviation. More electricity is going to the right. That could be from right ventricular hypertrophy, so lung disease quite commonly as a cause there. And then this one, last of the bunch, you can see that lead 1 is more positive, and similarly AVL are positive. Therefore, this is a left axis deviation. So more electricity is going to the left. You've got more muscle there. That's probably one of the more common ones that we see, so often from hypertension. But yeah, that's a left ventricular hypertrophy. And that's just a summary diagram of each one. I try and put in a lot of diagrams for revision, but it often makes the PowerPoints quite long, but hopefully helpful for your revision. So we've done name and date, calibration, rate, rhythm, axis. So now we're moving on to the actual waves. So we're going to look at the P wave first. So the P wave, as we said before, is the atrium depolarizing. That should be kind of about 3 small squares. To be honest, I very rarely calculate how many squares the P wave is unless the P wave looks weird. And the summary of most ECG interpretation is just try and remember what looks normal. And if it looks weird, then look at it in more detail, kind of step by step. So this depolarization happens from that sinoatrial node, which is at the top of the right atrium. So it means the wave, as you can see in that bottom diagram, is kind of formed from depolarizing the right atrium and then the left atrium, because it sort of spreads over both. So when the P wave is a funny shape, that will help us interpret kind of why. So the first question is always going to be, is the P wave actually there? Obviously, it won't be there if we don't have nice coordinated depolarization of the atrium. What sort of conditions do we not get a P wave in?
AFib.
Yeah, AFib. And obviously you see that a lot. It's a good, it's kind of nice spot diagnosis to begin with. So if you start any waves, there's no P wave, lovely. And hopefully by that point you'll have done your rhythm as well. So you'll have an irregular, no P waves. Does anyone know any other conditions we might see no P wave in?
Ventricular fibrillation.
Yeah, that's a good thought. So yeah, ventricular fibrillation obviously will just be a general mess. And actually a lot of our ventricular arrhythmias will kind of swallow up the P wave. And another condition that similar to atrial fibrillation and that the rest of the ECG will look relatively normal is atrial flutter. So you won't see a nice normal P wave. You'll see what we call a sawtooth baseline, which is that kind of jaggediness. So you won't see an actual P wave, similar to atrial fibrillation in its pathology, and that the atrium isn't contracting nicely. And that's a similar diagram of AF versus normal. So you've checked if the P wave exists and if it's there. We also want to know if it looks kind of normal. So you might get really tall P waves, which you can see on that bottom ECG there. That's often because of right atrial hypertrophy. So the wave is formed from the right atrium first. So if it's really tall, it's because there's a lot that it's having to kind of cover in the right atrium and then the left atrium. So that could be from lung disease, again, that kind of back pressure, so pulmonary hypertension. And again, that's quite, you sound quite fancy if you picked up that they've got peaked P waves on their ECG, because again, that will help you think in your head that there's clearly something going on here in terms of enlargement in that atrium. The other thing it might look like would be bifid P waves. So this is where the left atrium tends to be bigger. That, again, variety of causes, but something like mitral stenosis or an aortic stenosis even. I had one the other day in an aortic stenosis. So the left atrium's bigger, so the depolarization will spread over the right, and then it's got loads to do left on the left side, so it kind of creates this little M shape. Again, your P wave will last a bit longer than it normally will, and you get that characteristic shape. So again, a nice thing to pick up. The P wave might also be the wrong way round. That normally means it hasn't come from the sinoatrial node, so it's not kind of spread nicely over the atrium. It's effectively gone in the wrong direction. Which I think I'll talk about again in a little bit, but effectively we'll talk about that more when we come to the PR intervals. It will mean that the spread isn't coming from the sinoatrial node. It could be coming backwards from the atrioventricular node. It might be you've got an ectopic focus somewhere else. Obviously, because then it means it's likely that it's not a pacemaker that's designed to do the P wave that's causing that wave. You can often then go into weird rhythms and things, and potentially even AF from there. We want to know if every P wave is followed by a QRS, and that's going to be helpful when we come to think about our heart blocks in particular. So we've done name and date, calibration, rate, rhythm, axis, P waves, are they there? Are they normal looking, and is every P wave followed by a QRS? Kind of your key questions. Any questions at this point? So for shout out anything, any point if you need. So then we come on to the P.
I have a quick question.
Yeah, go for it.
Why is it that it's the second limb lead that's used as, or second chest lead that's used as the 10-second strip?
It just tends to be, so as it tends to be that most people's axis kind of points in that direction. So it tends to be that that's your clearest QRS because it's kind of the most positive. So it helps to identify any pathology. It tends to be one with quite a nice tracing. You'll notice sometimes you get tiny Q waves if effectively you haven't got that much electricity in that direction. So it tends to give you a nice tracing.
Okay, good, thank you.
All right, so our PR interval. Does anyone remember how long we're hoping that will last for?
Less than 120 milliseconds.
Close. There's lots of 120s and 200s in ECGs.
Oh, 200.
Yeah, so this is between 120 and 200. So 120 tends to be a QRS as the other one. So this is that kind of pause at the AV node. You measure it from the beginning of P to the end of R. And it should normally be about 120 to 200 milliseconds or 3 to 5 small squares. So if you have a prolonged PR interval, the kind of, well, obviously we're talking about our heart blocks, which I briefly mentioned earlier. Sorry about that. So in first degree heart block, effectively the PR interval is just greater than 200 milliseconds or 5 small squares. So you can see here there's quite a gap between the start of the P wave and the beginning of the R wave. It can be kind of normal. Often athletes can have a bigger gap there, and it can be from drugs that we use to try and slow down the heart, things like beta blockers or calcium channel blockers. If someone's on digoxin, always worth checking their digoxin levels for this. And it can be from an inferior MI, but just less commonly, and normally you'll have other signs to go along with it. If it's the only thing that's odd on your ECG, you shouldn't need to do anything about it. You might want to tweak their medications a little bit to bring them down if their heart rate's slow, but otherwise you're not going to be that excited. Sometimes beware, because the PR interval can be really, really long, and effectively the P wave can almost be swallowed up by the T wave, as you can see here. You've just got a kind of bump within your T wave. You can see it's still nice and regular, but it's worth trying to kind of map out where all the P waves are if you are worried. That's just another summary. So does anyone know what happens in second degree heart block Mobitz type 1?
It's like progressive lengthening of the PR interval until a beat is dropped.
Yeah, lovely. No, that's a good summary. So it's often got Mobitz type 1, or sometimes called Venkabat. As you said, the PR interval gets progressively longer, as you can see at the top there, until effectively the pacemaker gets fatigued and drops a beat. I always thought about, well, I was always taught it was kind of like teamwork. So you're in a team of one, you're desperately trying to work really hard, but actually then you just have to take a breath, drop a beat, and then the kind of same thing happens again. You get slower and slower, and then you drop a beat. And then what this one is normally again from reversible causes, often from medication, particularly beta blockers, calcium channel blockers, digoxin and amiodarone. Gets progressively fatigued and then can't actually create a QRS. This doesn't tend to need pacing. We don't tend to worry about it as much. If it's asymptomatic, we'll leave it alone. If they're symptomatic, they may need some medication if they're very bradycardic, but less rare, less commonly. And that's just another summary there. So conversely, what happens in second degree heart block type 2?
There's no prolongation, it's just a random drop of the QRS.
Yeah, so the PR tends to be longer, but as you said, it doesn't get progressively longer. It's just that it kind of drops a beat. So sometimes the PR can actually be normal length, but effectively it's that every P wave isn't followed by QRS. You sometimes can have a pattern like a 2-to-1 or a 3-to-1 block, or sometimes it can just be a bit random. The P waves will always kind of come at that constant rate, as you can see on there. Normally this is from a structural problem. This puts you at more risk of developing complete heart block or asystole. So these are the ones you're going to need to treat initially with drugs and potentially with pacing or a pacemaker. You can sometimes get some pretty slow rates with this of kind of 30s and 40s, which is always a bit worrying when you're feeling a pulse and you're thinking, oh God, when's the next beat coming? And for example, I would put these people on a cardiac monitor. So as you can see here, that's a 2-to-1 block. So although actually at one point it doesn't even do 2 beats, but that's more of a kind of patterned block. We tend to worry about type 2 more. As I said, it tends to be caused by more worrying things like an infarct or structural damage, and it's more likely to kind of cause you problems in terms of needing to be paced and having those issues like acute heart failure, syncope. Whereas we tend to worry less about Mobitz type 1. And then third degree heart block, that's the one where basically the atria and ventricles aren't talking to each other. This one is where you tend to get the severe bradycardias. The rates are going completely separately from the atria to the ventricles, and often the QRS that you get, because you haven't got the P wave causing the AV node to be triggered, effectively the QRS will come from somewhere else within the ventricles, or what we call an escape rhythm at a slower rate. This one tends to be the same causes as Mobitz type 2, and again we worry about this one, that your heart will suddenly stop, you'll suddenly go into an odd rhythm from somewhere else in the ventricles, and you need to be admitted and paced. And this one's quite satisfying because you can I tend to use the same technique I do with the rhythms for this. I'll do a little line for the P waves and move it along, and similarly for the QRSs, and they'll be completely not related to each other, but you'll see that the P waves are still regular and the QRSs are doing their own thing. Can anyone work out the atrial and the ventricular rates on this one? Sometimes the challenge with this is finding two P waves.
Is it 4 QRS at the lead 2, so times 6 is 24?
Yeah, worryingly low, yeah. And then what about your P waves for the atrial rate?
33.
Yeah, something like that. So I haven't worked out the specific bit. It's kind of about 300 divided by about 11-ish, looking at the P waves down here. I would say if you wanted to do the atrial rate the same way you just did the ventricular with the times 6, can be more difficult because P waves often get sort of swallowed up in the QRS. So I would often use the 300 rate for that, but no, that's right on both counts. So I put in a bit of emergency management for this. So again, if you had worrying symptoms, so shock, syncope, heart failure, or symptoms of an MI, then these people would need atropine to try and speed up their heart. And if that wasn't working, they're probably going to need transcutaneous potentially or transvenous pacing until you can get them a pacemaker. I bet that just explains a bit about atropine. I won't go into that in too much detail. For the temporary pacing, I said you can do transcutaneous. That's kind of where you put defib pads on and you give them electric shocks on the outside. Quite horrible to have done, and so we often try and give them some midazolam, and we try and use the atropine first to reduce our need of this. Or the ideal is that you whip them to go and have a pacemaker, but you can also pace them transvenously until that can happen. And they're just some pictures of those things happening. So as well as the PR interval being long in our heart blocks, you can also have a short PR interval. This normally means that the P wave isn't coming from the sinoatrial node and effectively just hasn't travelled as far, so it's kind of coming from nearer. It could have come from the AV node itself and kind of travelled backwards, and you might get kind of backwards P wave, or effectively it's come from somewhere else in the atria that's closer, and effectively it's had a bit of a shortcut. That could also mean that there's an accessory pathway, and we'll talk about Wolff, Parkinson, White in a second. And effectively the P wave has kind of come from the ventricle itself and not the sinoatrial node. If that'll make more sense. So this is what we call a junctional rhythm. So this is where the P wave has been generated from the atrioventricular node. You can see the P wave itself is upside down. There's no PR interval pretty much. And you could definitely tell it doesn't look right, but at least if you know some of the things about what's going on with it, you'd know this is probably from the junction because the QRS is still short. So it's then traveling its normal path after the AV node. But you can tell that that looks wrong anyway. So Wolff, Parkinson, White is one of those things that often comes up in question banks and things. So again, this is where you've got an accessory pathway, so it's not doing the nice sinoatrial node to AVN. You've normally got an extra pathway. Does anyone know what the extra pathway is called in Wolff, Parkinson, White? It's a bit of a random trivia.
Kent's bundle.
Yeah, bundle of Kent, well done. I mean, to be honest, that has proved no help to me in my medical career so far, but it's good to know. And effectively, it means that there's an extra track so that the electricity can go down. And as in these pictures, you can see that bundle of Kent tends to be on the kind of left, the right ventricular side. It means that the wave itself, you get a shorter PR interval because you don't get the pausing at the AV node. The QRS looks weird with the delta wave, which is that kind of upswing, because the whole of the QRS is coming from the right side rather than traveling down both tracks in the middle. So it just takes longer. And so your QRS is prolonged. And often you get T wave changes because the depolarization is a bit messed up. Is my summary of that. And that's what it looks like on a real ECG. And again, that's another quite nice spot diagnosis. And we worry about it because you've not got the control and the kind of pausing at the AV node. You can get re-entry tachycardias. So effectively the electricity just keeps going round and round and round, and that can cause VF or cardiac arrest. And that's an example of the tachycardia. You can still see that delta wave for the kind of upswing, which is shown there as well. So now we've done name and date, we've done calibration. Yeah, of course, go for it.
Can you go back to the previous slide, please? This one. How can we? No. The ECG slide.
Yeah,
yes.
that one. Yeah.
Between the Wolff Parkinson and the SVT in this slide.
And it is difficult. So really, Wolff Parkinson White in this scenario is a supraventricular tachycardia. So in that we've got a narrow QRS. So the tachycardia itself is coming from above it's supraventricular, it's above the ventricles. So this you could still call a supraventricular tachycardia. Effectively, the only difference is, and it's not the perfect ECG to see it, but I think it's particularly evident in lead 3 here. You've got that kind of upswing, which is called the delta wave. You wouldn't be wrong for calling this a supraventricular tachycardia, and you would treat it in a pretty similar way, to be honest. Although this will probably need magnesium and probably need shocking, to be honest. But it's technically still a supraventricular tachycardia.
I see. So the management between the Wolff Parkinson and the SVT is almost the same.
So what if you saw this, particularly because this is a relatively subtle Wolff Parkinson White, you'd probably have a go at slowing the rhythm. So you would do your normal vagal maneuvers, you potentially would give them some atropine. Effectively, when you'd slowed the heart rate enough to see what the rhythm is, you'd say, aha, that's Wolff Parkinson White. That would probably need more specialist management, I think, with amiodarone off the top of my head, but I'd need a cardiologist for sure. But you would initially manage it the same as an SVT anyway.
Thank you so much. Thanks.
That's all right. No worries. So as I said, we've done our name and I'm going to keep going over this because hopefully then we can apply this tomorrow. Done our name and date, we've done our calibration, our rate rhythm axis, our P waves, are they there, are they normal looking, are they all followed by a Q wave, our PR interval, and that's where we've got to now. So now we're going to do our QRS. So we're going to start with the Q waves. So I definitely didn't really understand what these were at medical school, but effectively they are the depolarization of the septum. They're normally quite small. You can't really normally see them. We worry about them when they are pathological, when we can see them more. Technically, so that's when it's more than 1 small square wide or 2 small squares deep. Or the one I tend to remember more is that it's more than 25% of the QRS, so look like this. You can get pathological Q waves in MI, which is why we worry about it, so ischemia, and it can also be from infiltrative myocardial disease. So I think this video explains the best as to what pathological Q waves are. So effectively, when you've had an infarct, that bit of the muscle becomes like a window because it's not actually working muscle anymore. It's not actually transmitting electricity as it should. Effectively, it'll be fibrosed and non-functional. And it means that the lead can see the Q wave a lot clearer because effectively you've got that dead bit of tissue in the way that's not doing anything. It's often thinner than normal. So it's not that there's any change to the actual Q wave, so the depolarization of the septum. It's just that there's a bit of dead tissue somewhere that means you can see it more. Does that make sense? Hopefully. I think I quite like this video for explaining that anyway. I'm not very good at drawing, so it does it better than I can. And let me know and feel free to shout out if that doesn't make sense. So that's the Q wave, and then we're going to move on to the QRS. And again, I think this is another bit that often confuses people, which is bundle branch blocks, which we'll get on to. The main thing we're looking at with the QRSs is it broad or narrow? So is it less than 120, that key number? So is it less than 3 small squares? We measure it from the beginning of Q to the end of S. Effectively, you're broadly looking similar to those 2 pictures at the top. Is it nice and thin, or does it look wider than normal? So if it's nice and normal, tends to mean it's travelled normally from the atrioventricular node, so it's gone down the bundle of His and then your bundles and up round, because it's all then all that electricity has gone over the ventricles quite quickly. So either it's kind of come nicely as normal from the sinoatrial node, you've got a lovely normal P wave, you've got a normal ECG. It could be that it's come from somewhere else in the atria, like your atrial fibrillation or flutter, So you've still got electricity coming down that pathway, but something's gone wrong at the top. So you've got your nice normal QRS, but no P wave. Or it could be that you've got a rhythm coming from the junction or from the AV node itself. So that might be, again, where you've got your upside down P wave, a short PR interval, but a nice normal QRS. So they'll be nice and thin like this. Broad QRS complexes, so these are where they're greater than 120 milliseconds or 3 small squares. In exams, this is quite commonly from bundle branch blocks, or as you said, in Wolff Parkinson White, you do get a longer QRS because it's kind of all going from one side. It could be a funny ventricular pacing rhythm, so like a ventricular tachycardia. We'll cover that again tomorrow. And if you have a broad tachycardia, it's ventricular tachycardia until proven otherwise, or something like hyperkalemia, which again we'll cover tomorrow. I'm going to talk through right bundle branch blocks, but I'm going to try and show a video, depending on how well that works, because I think watching them draw it out makes a lot more sense than me talking about it. Right bundle branch block basically means, so obviously normally, again, the electricity comes down the middle and up the sides, down our bundle branches. In right bundle branch block, the right bundle isn't working because of ischemia or infiltration or something like that. It means the left ventricle gets depolarized as normal, but then all of that electricity has to find a new way to get through to the right ventricle. So it just takes a long time, hence the QRS is longer than normal, and you get a kind of second wave. That's kind of a diagram show you it doesn't go down its normal right bundle as normal. So you get a kind of second wave spike in we tend to look at V1 and V6 because they look at the opposite ends of the heart, and sometimes this is called a marrow because it can look a bit like an M in V1 and a bit like a W in V6. So you can see that shape here with the kind of M and very positive shape in V1, and then V6 the kind of W-ish shape. But again, I'll show you on a video because I think it makes more sense. And that's another example. So that can be caused by infarction. It can be PE or kind of big strain on the right side of the heart, right ventricular hypertrophy and kind of stretching the electrics of the heart, cardiomyopathies, for example. And left bundle branch block is similar in that, again, your impulse isn't going to go down the left side, so all of the impulse goes down the right and then has to find a new way to get to the left, so it just takes a lot longer, and you get a kind of bigger spike in V1, which kind of causes your William shape. So in this one, you get a very negative initially in V1 and very positive in V6. Which you can see on some real examples. And again, even if you just spotted that QRS doesn't look right, it looks broad, then that's enough that it shows that you know what's going on with this ECG. And then the more you look at, the more you can recognize. Similar with this one. And again, this can be caused by infarction, hypertension, strain on the left, so stretching those electrics, aortic stenosis, for example, or any kind of fibrosis, etc. I'll see if I can get this video to work. I guess the sound could be another thing. But even if we don't have the sound, I can narrate. Can you guys hear that as a start? Well, see it and hear it.
We can't see it. I think that you have to share your either your entire screen or the
new share,
the specific window. Yeah.
Oh, I see. Can you see it now?
Yes.
Can you hear it?
No.
Did you hear that sound?
No.
No, that's fine. To be fair, she's got quite an annoying robotic voice anyway. Not that my voice is any less annoying, but I'll kind of talk through what's going on. Let me just find the right section. It's right here. I think it's just quite a nice animation to explain. So this is saying that V1 and V6 are the right choices because it helps to see the spread from right to left, because that's where they sit. So saying with our normal, we normally get that little Q wave from the septum, which they'll draw for us now. And obviously the left ventricle has the biggest amount of muscle, so that's normally why we get the biggest spike towards the left, so away from V1 towards V6, hence that's why they look like that. So this time our Q wave is normal because we're still going from right to left, left to right. So we start off with a kind of normal depolarization of the left, which is normally the bulk, but then we've all got to go to the right, so effectively then go to the opposite side of normal. Hence, you get this little. That's where we get our marrow, because it looks a bit like an M and a W. And this time our septal depolarization is reversed. So we get a kind of opposite Q wave. And then it all goes to the right and then following to the left. So that's worth watching a few times, I think, to help you understand. Right, can you still see my screen? Because I think I changed my settings.
Yeah, we can see.
Excellent. So bundle branch block is still tricky, and I said we'll do plenty of practice of lots of ECGs tomorrow, including bundle branch blocks, to hopefully make it a bit more sense. Again, fire away any questions if you need them. So we've done name and date, we've done calibration, rate, rhythm, axis, P waves, are they there, do they look normal? Are they all followed by a QRS, PR interval, Q wave, QRS, does it look normal, is it broad or narrow? The other thing we can look at with the QRS is R wave progression. So normally from V1 to V6, effectively it goes from quite a negative wave to a positive wave, and you can see that on the middle of those ECGs there. Normally it transitions about kind of V3 to V4, where it's kind of a bit half and half, negative and positive. If you get a change in that progression, it normally means that the electricity's had to bypass something. So that's why it doesn't look normal, and that's as technical as you need to know. So often that means it will take a long time for it to get positive, or get positive really early, and you'll get a change in the R wave progression. I'll show you an example. So yeah, normally we get this transition from very negative to very positive about V3, V4. You can see on this example, actually, it doesn't really get positive until V6. So we would call this poor R wave progression. So when you're presenting back, you could say this poor R wave progression that could show the signs of previous ischemia. Again, you might have other signs. So on this one, you can see they've also got some T wave inversion V4 to V6 on there. So again, that all kind of fits together in that picture. That's just another thing that you can look at. Similarly on here, you can see it's kind of negative, negative, negative. I'm kind of covering that bit of the screen, but I think it goes negative, 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 and again, kind of positive in V6. So we'd call that late R wave progression, can be a sign of ischemia. We're looking at V1 to V6 with that. And then we're kind of getting on to the ST segment. I think that's probably the bit that excites everyone the most, because more exciting bits happen in ST. We'll do this bit, and then we've got to talk about QT interval briefly, and then T waves, and we'll leave today's session. Tomorrow's will be a bit shorter, but it'll be more ECG heavy, and we'll apply everything we've done today. So the ST segment is that interval between ventricular depolarization and repolarization. So obviously we get excited with ST elevation because we think of ST elevation MIs, or kind of heart attacks basically. What we're looking for is an elevation of more than one small square in 2 limb leads, or 2 small squares in 2 chest leads. So the chest leads are the 1 to 6, V1 to 6, and the limb leads are the 1, 2, 3, AV, L, R, and F. The thing we're looking for, as we said, is a STEMI, but it can also be raised in pericarditis or tamponade. I'll show you an example. So if you get a question that's a sort of 30-year-old with a recent cold who has an ECG and there's ST elevation everywhere, it's probably pericarditis rather than them having a massive STEMI. But we'll have a look at some examples.
Just to clarify this one, if we found ST elevation in all leads, this 100% pericarditis or tamponade? directly?
So,
Like this?
I mean, they could, obviously it kind of depends. So if you've got an unconscious person who's just had a cardiac arrest, who has lots of risk factors for a STEMI, it could be a massive STEMI, but it would have to be blocking off basically right and left coronary arteries, so they'd be dead pretty much. But if they're more well, or the story doesn't fit with a STEMI, then it could be pericarditis or tamponade. And I'll show you the ST elevation in pericarditis doesn't look quite the same as it does in a STEMI. I'll sort of show you the difference with some examples.
How can we diagnose the pericarditis or tamponade other than the ST elevation from ECG?
So from an ECG, there's probably not that much difference. They might be slightly tachycardic for both of them. The other things, so if I was concerned, some of it's going to be a history. So in a younger person with a recent virus, it's more likely pericarditis. Tamponade, you're going to get other signs. So you're going to have muffled heart sounds. You're going to get a raised JVP. You might have signs of acute heart failure because the heart can't expand. So they're going to be clinically quite different. But if you're worried, I'd get a bedside echo, would be my main test. But probably from the ECG, there's not going to be that much more that you can tell.
Thank you so much. Thanks.
That's all right. So ST elevation can look all sorts of weird different ways. And often, sometimes you'll sort of be doubting yourself, is that ST elevation, is it not? Obviously, some of these are quite obvious, but I tend to get a piece of paper and have a look to see if it's all the same baseline or if there is a rise from the baseline. Because obviously, in real life, patients don't sit perfectly still. The ECGs are a bit wibbly wobbly. So I always just check that it's kind of along the same line. You can see some of these are more dramatic than others. Those bottom two we often call tombstoning because that's a sign of really severe ischemia, and effectively it's a bad sign, hence we often call it. It looks a bit like a tombstone, but also you're in trouble if that's what your ECG looks like. I'm briefly going to talk about acute coronary syndrome. Again, I've put some treatment bits in here which may be slightly different to what you guys taught, but hopefully it'll be helpful nonetheless. Acute coronary syndrome is made up of our ST elevation MIs, our non-ST elevation MIs, so we don't have ST elevation, but we do have a rise in troponin, or unstable angina, where we don't have troponin rise and we don't have ST elevation, but we might have other signs on the bottom too. With our ST changes, this is where it becomes really important in terms of what bits look at what of the heart, and this is all to do with the coronary artery anatomy. Again, I was rubbish at anatomy at med school, so I hated diagrams like this, but I think this one's quite helpful. So as a reminder, the left coronary artery comes around and supplies the left circumflex, which does the kind of lateral part of the heart, and then comes down and does the left anterior descending. The right coronary artery, normally in most people, comes round the kind of side as your acute marginal, and then in 80% of people goes down the back and becomes the posterior descending artery and does the inferior part of your heart. In 20% of people, it's the left circumflex, and we'll talk about how we can spot those differences on an ECG. So it's going to be important to know what coronary arteries supply what, and also what leads look at which bits of the heart, which we'll go over. I've just put a few other diagrams in because I'm a visual person. This is a bit of a summary. So again, we talked about before that the anterior of the heart, for example, is looked at by V3, V4. So if you've got big ST elevation there, you're probably convinced it's a LAD, or a left anterior descending lesion, for the anterior of the heart. Once you're a bit more comfortable, this will make more sense, but these are the different areas that the heart looks at. So we said 2, 3 and AVF kind of come from the floor, so they look at the bottom of your heart. So if you're having an inferior MI, that's where you'll see the changes. Anterior is kind of V3, V4, septal V1, V2, V5, V6 kind of look at this side, but so does lead 1 as well. The top of the heart is kind of 1 and AVL. We'll go through each one. If someone's having an ST elevation MI, obviously they might have ST elevation, is kind of the most common finding there. And as we said, it's 2 small squares in the chest or 1 in the limb leads. They will often, if you see ST elevation on the opposite side of the heart, so for example, if someone's having an inferior MI, one of the top leads, so AVL or AVR, or 1 might have a reciprocal, so kind of opposite ST depression, which I've got a picture of, so it'll look like that. Also means if you see ST depression, kind of check the opposite leads to see if you can see any signs of elevation. You might get pathological Q waves, which we've talked about, and if someone has a new left bundle branch block, that can be a marker of a STEMI, basically. So that's another criteria for sending them for some intervention. So where can anyone see any abnormalities, particularly not ST segment here?
This is in lead 2, lead 3.
Yeah.
And
Anywhere else?
we do have in V2 to V3, and
Yeah.
we do have in AVF.
Yeah, so definitely I would agree with you.
depression.
2, 3 and AVF, and they tend to all, if you've got ST elevation in 1, you tend to get them in all of those because they all point in the same direction. It's hard to tell on this, and again, I would be getting my bit of paper out. So I don't think we have any in F2, V2, V3. I agree with you that we have depression in AVL, and again, that sits opposite to where the other leads are at the bottom. I said there's a lot of miming involved with this. So I think this is mainly going to be some ST elevation in the inferior leads 2, 3 and AVF with reciprocal depression in AVL. If that makes sense. So I think we've got an inferior STEMI here. That tends, it'll be a different artery, again, depending on what supplies that posterior descending artery. Most people, it'll be the right coronary artery. With that, we tend to see signs of particularly the lead 3, because it's coming from the right, lead 3 tends to be more affected. So you tend to get bigger ST elevation in lead 3 compared to lead 2, if that makes sense, because it's coming from the right, so it affects that side more. Whereas if people are supplied by the left circumflex that comes down and makes the posterior descending, you tend to see signs of lateral infarction, so V5, V6 as well. I'll try and, I think I've got an example. And that's just a reminder of the anatomy. So what about this one?
In lead 2, there's ST elevation.
Yeah.
And 3 as well.
Yep. Anywhere else?
Also in lead 1,
too.
depression.
Yeah, AVF. And then sorry, I didn't catch the other bit.
We do have in lead 1 AVL.
Yes, lead 1, yeah.
2,
Yeah.
there is depression.
It's depression, yeah, I would agree.
Yeah. So this is inferior anterior lead 1 to.
So yeah,
And
so
V6 little bit.
a little bit, yeah. But I think we all agree most of the ST elevation 2, 3 and AVF, that looks the most dramatic for sure. And then as you said, the opposite leads 1, AVL and AVR all have the ST depression. Can you see that the ST elevation looks worse in lead 3 compared to lead 2? And although we've probably got some subtle changes in V5, V6, we don't particularly have big ST elevation. So this would be an inferior MI, she says, inferior MI, probably from the right coronary artery, just because it's affecting that right side more, and we don't particularly have any changes in V5 and V6. Does that make sense?
May I ask you a question?
Of course, yeah.
So in lead 2, lead 3 and AVF, we can find that the ST elevation, while in lead 1, AVL and AVR, there is ST depression, and even a little bit in V2, from V2, also we do have the depression. Is it the mirror lead? This is what
Yeah, so basically mirror. So it's the reciprocal depression. So that just means basically they're mirroring. So because you've got so much awful stuff, this is as technical as I'm going, but there's so much awful stuff in the inferior going on, effectively in the leads that are mirroring them, which, so we've got an inferior MI, so that'll be the ones that look at the top. So 1, AVL, AVR, you're seeing the mirroring of that, so ST depression. So yeah, this would be with reciprocal ST depression would be your fancy way of saying that, basically. More spot the STEMI. Where can we see any problems in this one?
ST elevation in lead 1.
Yep.
And then depression in 3. So this is like.
Any other places that you're worried about? So
V6 and lateral, like left circumflex artery, maybe.
potentially. What about the other chest leads? Any worries?
The V1, V2, and V3.
Yeah. Any others? This is quite a nasty ECG, to be honest.
V4 as well.
Yeah, so this is actually, I'd say we've got big ST elevation, and it can be difficult to see because it's turned into a really funny shape actually. But in V, kind of 1, but mainly 2, 3, 4, and 5, we've got big amounts of ST elevation. I agree with you, definitely lead 1 and subtly V6 and V1. And then any, I can't remember if there's any on this one. And probably subtly some AVL, some slight ST elevation as well. So where do the kind of V2, 3, and 4, where do they point at in the heart?
This is the anterior wall MI.
Yeah, what's the likely culprit artery?
I guess this is the LAD.
Yeah, so it's probably left anterior descending. To be honest, this is quite a big one. So as you said, it's covering most of the anterior of the heart, but also we've got signs in 1 and kind of AVL. So this could actually be a left coronary artery, but it's definitely affecting the LAD, and it might be slightly further up than that. I think I've called this I called that the left anterior descending. So the LAD area, that often it covers quite a big area, so you get quite dramatic ST elevation. It obviously, depending on where it comes in, that, so if it's right at the top of the left anterior descending, you're basically knocking out your entire front of your heart, hence you might get V2 to V5. If you're knocking out a further down branch, so if it's just actually like the septum or like the smaller amount, you're probably blocking further down. So that's why it's important to know it's kind of septum V1, V2, anterior V3, V4, and kind of lateral side V5 to 6. So again, you'll spot those patterns as we go. We'll do plenty of this tomorrow as well. What about on this one?
I see an ST depression in lead 2, 3.
Yeah, I would agree.
And an elevation in lead 1, I think.
Yeah, I would say a little bit in lead 1, yeah. What about our other leads?
And AVF, so we have 2, 3, and AVF ST depression.
Yeah.
So this shows us that it's an inferior wall.
Well, so you've definitely got ST depression in, I agree, in 2, 3, and AVF. So that's obviously the bottom of the heart. If you see ST depression, I would always look for ST elevation in the opposite part of the heart. Because obviously the thing we worry about the most is ST elevation. ST depression, still not good, but obviously we need to rule out a STEMI. So we kind of need to look at the opposite bit for ST elevation. Any signs of ST elevation that anyone can see?
V3 has the.
V3, yeah.
Actually, I mean, V2 is from V2 until V6, there is ST elevation.
Yeah, so I would agree with you. So I think V2 to V6 ST elevation. Any other ST elevation?
In AVL, there is ST elevation.
Yep.
And I guess the lead 1, of course, there is ST elevation.
Yeah, and then as we've said, there's some reciprocal depression in 2, 3, and AVF. So what sort of areas of the heart are we covering here? So we've said kind of V2 to V6, but then also 1 and AVL. Again, lots of miming. And yeah, AVL. Didn't quite catch that.
The
lateral one?
Anterolateral, yeah, I think that's what the other person, sorry, the other first person was a bit quiet, so I didn't quite hear that, but yeah, anterolateral. So this is again a really big MI. This potentially is probably kind of further up in terms of the left coronary artery to be wiping out so much. That would have a poor prognosis. And again, well identified for the ST depression reciprocally. But if you see ST depression, just check that you're not missing ST elevation. That's just another example there. So you can get pure lateral STEMIs. So again, this particularly is if we're affecting the left circumflex. Often you have lateral in association. So again, you'll wipe out a bit of your kind of anterior as well, because it tends to be also the branches of LAD could be affected. If it's a pure lateral, it will just tend to affect 5 and 6, 1 and AVL, and then you'll get the depression opposite side. So 3 and AVF often. Again, I'm just going to keep flashing up that picture because it helps for me to think about the anatomy as well. What can anyone see on this one?
ST elevation in 1 will
Yeah.
be 5,
Yeah.
V6.
Yeah, no, I would agree with you. Any other changes we can see?
And AVL, I think there is
AVL, yeah, no, I would agree with you.
This is 1 AVL, V5, V6 is the lateral wall in my.
Yeah, lovely. So yeah, as we just talked about, so and then we've got the reciprocal changes again, so you can see that ST depression in 3 and AVF. Good, you guys are on this. So you can also get posterior MIs. Obviously, we're not very good at looking at them because all of our leads kind of don't particularly point towards the back of the heart. Often, if you get a posterior MI, it's because you're having a massive MI, you've wiped out most of your heart. But obviously, you can get small branches that do just supply the back of the heart. We're not very good at looking at that, so often we'll add extra leads to have a look. Subtle signs that you might be having a posterior MI without adding the extra leads are that you'll have ST depression in kind of V1, 2 and 3, so that's looking at kind of the septal nearly getting to the back of the heart, and it'll be that kind of mirroring effect. So if you've got pure ST depression in kind of your chest leads, it's probably worth whacking some extra leads on the back, and I'll show you some ECGs for that to have a look to see, just to check you're not actually having a STEMI in the posterior of the heart, because obviously that will change your management compared to if they're having a STEMI versus an N-STEMI. So that's trying to show that kind of mirroring effect. So where we tend to put the leads is we'll do a V7, 8 and 9. So we tend to put them kind of below the left scapula in that sort of position. As you can see on this one, we've got some ST depression, V1, 2, 3. I would also argue we've got some ST elevation in V6, probably 2, maybe 1 anyway, but I would want to look at the back of this one because we've got such deep depression in V1, 2 and 3. So this is probably, as you can see, we've got lots of changes, probably infralateral, inferior, lateral and posterior. But if we were to flip it over, so they added some leads to 7, 8 and 9 at the back, you can see we do have quite pronounced ST elevation in 7, 8 and 9 basically, which shows we've got the posterior included. That's the same patient as before. Similarly, on this one, we've got ST depression again, kind of V2, V3, V4. We've got probably a little bit of ST elevation in 3, but it's a bit more subtle. And when they added on the extra leads, you can see again, we've got some subtle ST elevation, 7, 8 and 9. So they were having a posterior STEMI. So that's quite a good management plan. If you've just got ST depression, you could add doing a posterior lead ECG. Now again, if you get an exam question like a 40-year-old with recent viral illness who has central pleuritic chest pain, which is worse lying down and better sitting up, and you get this ECG, you can probably see, it's not a brilliant trace to be honest, that 1, 2, where else is it obvious? 1, 2, V2, V3, V4, V5, V6, you have got some ST elevation there. It's not a brilliant trace, so you can't see it in every lead. And can you see that the ST elevation is a bit more kind of curved in shape? Now in medicine, obviously everything is normally named really unhelpfully, but this is what we call a saddle ST elevation. So this is what we'd see in pericarditis. So it's meant to look a bit like I'm going to do a terrible drawing here, like an old-fashioned cowboy saddle. So rather than it being kind of right up, oh God, can you actually see that? Yeah, so it tends to be a bit more kind of curved in shape. It's also affecting a lot of the leads. They are young, they've had a recent viral illness, they have pleuritic chest pain. It's unlikely to be a STEMI, and that's what we call more kind of pericarditis type changes. So it's, again, it tends to affect a lot of the leads. Obviously, if they were actually having an MI and it was affecting that many leads, they'd be incredibly unwell. So instead, this is more likely to be a pericarditis. And instead of giving them lots of STEMI treatment, we'd give them NSAIDs and some colchicine potentially. And then to talk about ST depression, so obviously it could be a reciprocal change from the ST elevation, or it could be a change seen in an N STEMI, so a non-ST elevation MI. It could be that you've actually got a posterior MI and you need to kind of flip your leads, or you can see it in hypokalemia as well. So basically you're just looking for that drop compared to the baseline, which you can see some examples of there. And again, it's not always beautifully shaped as if you were designing an ECG yourself. So some of these images aren't brilliant. So sometimes it's a bit more sloped or a bit more flat, but basically you're going to be looking for those, get that piece of paper and check compared to the baseline. And some helpful arrows, which is nice when they include those, but you can see that ST depression. Again, if I see ST depression, I'm always going to check for ST elevation in the opposite leads, which I can't see on here. So that would be an ST depression. That's a slightly more obvious ST depression on that one. And just because I think it's helpful to chuck some management in there, if you had someone who is having an ACS, so be that STEMI and STEMI unstable angina, you tend to give them MONA, so morphine plus some antiemetics, oxygen if they're hypoxic, nitrates and some aspirin. I'm assuming that's pretty similar with you. And I've put some of our guidance in for STEMIs, which feel free to go over in your own time because it might be slightly different. I don't want to throw you off, but I just put them in from my old slides. So we're nearing to the end of day one. You guys are doing well, sticking with me. But so far we've done name and date of birth, calibration, rate, rhythm, axis, P waves. Are they there? Do they look normal? Is every P wave followed by a QRS? PR interval, Q waves, pathological, QRS, does it look normal? R wave progression, ST changes, ST elevation or depression. We'll just now do QT interval and T wave, and then we will cut this evening and do lots of practice with these tomorrow. So I've got a load of examples. So QT interval, we're looking at the beginning of Q to the end of T. This is for how long it's basically taking the ventricles to depolarize and then repolarize. It's inversely proportional to the heart rate. So obviously if your heart rate is going really, really fast, then it's going to take less time for your heart to depolarize and repolarize. So you have to correct it compared to the rate. We definitely didn't have to remember how to do that, but I have put the calculation in case you guys needed to know how to do it. To be honest, I tend to broadly count on the ECG just to check it doesn't look wildly abnormal, and then I check when it gives you the numbers to make sure it's not wildly off. I'm definitely not doing these calculations myself. So if it's prolonged, lots and lots and lots and lots of causes of that, particularly medication related. So often our antipsychotics are super common, and that's why you need to do ECGs to kind of check a lot of the anti-epileptic medications, some antiarrhythmics like amiodarone, lots of antibiotics, lots of electrolyte problems, so hypokalemia, hypomagnesemia, hypocalcemia. We want it, it's prolonged if it's greater than 440 in men and 460 in women. But I always just have a little broad count, and if it looks above 450, I'll either check that the computer's calculated it for me, or I will kind of whip out a calculator. We worry about it because if you have long QT, then you're more likely to get ventricular arrhythmias, as you can see here. So particularly torsades de pointes is the one you're looking at. So effectively that's a polymorphic ventricular tachycardia. And again, we'll do tachycardias tomorrow in the session tomorrow. That can cause effectively cardiac arrest and VF. And it basically it's because the heart's taking ages to depolarize and repolarize, so more extra rhythms can kind of shoot in and cause all the electrics to mess up. Is as technical as you need to know. And then finally, just T waves. So this is definitely the thing I found all of my students, if they had no idea what was going on with an ECG, they'd all plump for tall-tented T waves, because sometimes the T waves can look a bit weird. The T wave itself is the ventricular repolarization. They're normally upright in all the leads, other than so often they're upside down in AVR or lead 1. So don't be too worried if they're inverted in those limbs. Effectively, they should be in proportion to the QRS. So on there it says they should be less than 5 millimeters or less than 10. If you've got a QRS that's absolutely massive, so someone's got big hypertrophy, then the T wave tends to be bigger because you've got more mass to repolarize as well as depolarize. So as long as it's kind of in proportion, but if it's the same height as your QRS, then you can tell something's wrong. So obviously that doesn't look normal. The T wave is nearly as high as the QRS, and that would be our tall tented T waves in hyperkalemia. But we'll go over hyperkalemia and ECG tomorrow. So again, that's more tall tented T waves. And then the other thing we think about is, are actually they the right way up or not? So obviously T wave inversion can be a sign of ischemia. Either you've had a previous MI or you're having an MI, and we like to look at serial changes. So these might be the people who are having multiple ECGs to say, okay, actually they are getting more T wave inversion. There's clearly some ischemia going on here. It can happen in anything that causes strain on the heart though, so PE, general illness, sepsis, bundle branch block, often because your electrics are obviously all a bit messed up, but it's a good thing to spot if they've got T-wave inversion. So in summary there, as I said, we've done the time and the date, the calibration, rate, rhythm, axis, P waves, are they there, PR interval, is every P followed by a QRS, pathological Q waves, QRS broad or narrow, good R wave progression, ST changes, QT interval, and T waves, which is quite an intense first session. And I think it only really clicks when you then interpret ECGs in this fashion, which we'll do tomorrow. I said tomorrow we'll do some tachycardias. We'll also do some kind of drug and electrolyte ECG, like the effects it has on it. And then we'll just do lots of practice and hopefully some pattern recognition, but also some practice of the things we've learnt today.
Excuse me.
Yeah.
I guess my colleague wants to talk, so he can.
Oh yeah, go for it.
Okay, can I say?
Yeah, go for it. Sorry.
Yeah, actually, can we get the video recording?
Yeah, I think they have been recording it. So I think I said I was happy for it to be shared, didn't we? So
yeah.
Yes,
So the seminar has been.
Yeah, sorry, keep going.
So yeah, the seminar has been recorded. Tomorrow's seminar will also be recorded, and it will be uploaded onto the website, like Surangama said. And another thing is that tomorrow, I'll be sending out a link where you guys can get a certificate of attendance to the ECG seminar. And all you have to do is fill out a quick survey, just some feedback for us and for Charlotte.
Much appreciated.
And yeah, just a big thank you for everyone that came today. I'm sorry that there was a bit of a hassle. Honestly, it's my fault. There was a bit of miscommunication. And a big thank you to Charlotte, and we will see you tomorrow.
Yeah, perfect. And I'm also happy for my slides to be shared after this as well, but after tomorrow's session. Yeah.
Okay, great.
Thank you so much.
That's all right. See you guys tomorrow. Anyway, thanks for staying with me for the hour and a half. So
thank you so much, Charlotte.
That's all right. Have good evenings anyway.
Take care. Bye.
I'll hang around in case anyone does have a question or anything.
Sorry, once again, just I would like to ask about the posterior volume eye.
Yeah,
in case we suspected that the patient has posterior volume eye, we should do the posterior or the back leads which is
Yes.
from V7 to V9, correct?
So effectively, yeah, you just stick the stickers on under the left scapula, and then you'd attach the lead. So as long as you, because obviously the leads are labelled, so they'll say like V1, 2. So as long as you know which ones you're connecting, because obviously on the screen it won't say V7, 8, 9, because you can't really program it to do that. So as long as you know you've put V4, 5, and 6 on there, then that's what it'll be looking at. So you just pick 3 of your chest leads, connect it to those stickers, and then you'll be able to view the back of the heart.
Thank you. One more question, please. In case you do have the posterior wall MI, is it the same management with other MIs?
Yeah, so the difference would be obviously, so if it's a STEMI, then you want to do your STEMI treatment, which is why it's so important to know if it is a STEMI or not, in terms of they might need to go to the cath lab and have like percutaneous coronary intervention. Whereas if it's an ST depression, so it's actually an N-STEMI, then that's when you're going to do a slightly different management. Well, it's different here anyway, in terms of you'll risk assess them, work out who needs to go for PCI, and then you'll give them their second antiplatelet and things. So you just, all you really definitely need to know is if it's a STEMI versus an N-STEMI, and that's why if you're not sure, worth checking if they are having a posterior STEMI.
Thank you so much. Thanks.
Yeah, no worries at all. Lovely. If anyone else has got any questions, I'll hang around for a minute or so, and if not, feel free to ask me tomorrow.
Okay, so I think we don't have any more questions coming in because we have like 3 more participants except
yeah,
you.
that's fine. I will run off then, but yeah, I'll.
Thank you so much, Charlotte.
That's right, no worries at all.
Tomorrow, and hopefully we won't have this confusion tomorrow.
Honestly, it's all right. No, I'm just glad that people still attended, and hopefully it was okay. Anyway, but
it's great. Thank you so much.
That's all right. No worries. Thanks, Pete.
Okay, so I'll end this meeting now.
Yeah, perfect. Thanks.
Perfect. Bye-bye.